Hello, and welcome to the August episode of Discussing axSpA, our axSpA podcast series where we bring you up to date with the latest research and publication in the field of axial spondyloarthritis. My name is Sofia Ramiro. I'm a consultant rheumatologist and senior researcher at Leiden University Medical Center and Zuiderland Medical Center in the Netherlands. Today, I'm joined by Xenofon Baraliakos, Professor of Internal Medicine and Rheumatology at the Hoor University in Welcome, Xenofon.
Thank you, Sofia.
So if you would like more information on the papers we discussed today, please head over to the Immune-Mediated Inflammatory Disease Forum website at www.imidforum.com, where you can view full slide summaries of these publications. Today's discussion will focus on two papers. The first, looking at the effectiveness of ixekizumab in real-world patients with axSpA and PSA, and the second, at the real-world comparison of clinical effectiveness of upadacitinib, TNF inhibitors, and IL-17 inhibitors in patients with axSpA after switching from an initial TNF inhibitor. So interesting topics to go and to discuss. And now it's over to you, Xenofon.
Yeah, thanks so much. And indeed, I think these publications are interesting for our listeners because they do have to do with daily practice. So I'm really happy to discuss them with you. So our first paper is a recent publication from myself and other colleagues entitled "A Real-World Comparison of Clinical Effectiveness of upadacitinib, tumor necrosis factor inhibitors or interleukin-17 inhibitors in patients with axial spondyloarthritis after switching from an initial tumor necrosis factor inhibitor treatment." And what we tried to do there was to take, obviously, the information that we know that initial treatment of spondyloarthritis focuses on maintenance of mobility, of physiotherapy, and minimization of joint inflammation using non-steroidals. And that's, of course, we know that biologics are the next step in treatment, such as TNF blockers would be one such biologic treatment. However, we also know that, unfortunately, this TNF blocker treatment, as one of the first biologics we've also ever had, is insufficient in about 40% of the patients. We also have IL-17 inhibitors, JAK inhibitors, which are now approved, or since years, approved in the treatment of spondyloarthritis. Now, regarding JAK inhibition, upadacitinib is approved to treat both active radiographic and also non-radiographic axial spondyloarthritis. We don't have yet any other JAK inhibitor to cover both of those stages of the disease, and it does show efficacy and safety in patients with inadequate response or intolerance to NSAIDs or a biologic therapy. This means, obviously, TNF blockers. The efficacy comparisons between upadacitinib and other advanced therapies are lacking, especially in those patients who are inadequate responders. And what we tried to do was to compare real-world effectiveness for pain and inflammatory joint burden reduction when switching from the initial TNF blocker to upadacitinib, IL-17 inhibitor, or any other TNF blocker. So in fact, if somebody is aware of the recommendation step, it's about phase 3 or step 3 in these recommendations in axial spondyloarthritis. So we also had analysis by patient sex and stage of spondyloarthritis as well. So what did we find? And I think that's exactly the topic we need to discuss in detail later on, is that in those two stages that were analyzed from the studies, radiographic spondyloarthritis was the most common form of spondyloarthritis, affecting 60% of the patients, I would say as expected. And that 80% of the treatment switches were due to worsening of condition or secondary lack of efficacy. This means this was not there were not patients who did not tolerate the injection or so. It was really a lack of efficacy at some point in time. At the initiation of the secondary advanced therapy, most patients in the entire cohort were reported to have moderate disease activity, about 55 to 60%, and they had been on their most recent treatment for an average of about 3 years plus minus. So it was towards 7 plus minus 2.9, so about 3 years in the average. Significantly higher proportions of TNF inhibitor upadacitinib group achieved total pain resolution compared to TNF inhibitor IL-17 inhibitor group. This means the change to UPA was favorable as compared to the IL-17 inhibition in terms of the pain resolution. And regarding then the reduction of pain, significantly high proportions in the TNF to UPA group achieved 2 or more points of improvement, or 33% reduction of pain, and 50% reduction of physician-reported pain compared to TNF blocker treatment. So the switch from TNF to TNF blocker was lesser good, or achieved lesser good results as compared to the change to baricitinib from the first TNF blocker. Also, significantly high proportions of TNF inhibitor to UPA group had achieved less than one affected joint at the end of or no affected joints compared to the TNF to IL-17 inhibitor group. So the peripheral involvement was compared here. Finally, also significantly high proportions of patients in the TNF to UPA group had less than one affected joint and no affected joint. So altogether, both the pain and the peripheral manifestations were affected when switching to UPA in this analysis. So altogether, to sum it up, there were greater proportions of patients experiencing reduced pain and lower joint burden when switching from TNF to a blocker to baricitinib compared to cycling to another TNF or switching to an IL-17 inhibitor. These outcomes improved regardless of patient sex and axis spondyloarthritis subtype following this treatment switch. And of course, we need to discuss also this real-world study that suggests that initiating with baricitinib after failure to achieve disease control with an initial TNF blocker could improve outcomes for patients with axis spondyloarthritis. Again, under these circumstances that we have excuse me, in daily practice. So that would be in a nutshell what we have found, and I know how critical you are about this kind of study sometimes, but I think we are also both agreeing in that, and I'm really happy to get your comments on this.
Thank you very much, Xenofon, for this presentation, and it's good now to discuss, I think, this paper. And I think we have good news in general here, because in daily clinical practice, there is an important number of patients, or proportion of patients, who are treated with TNF inhibitors and then who are not optimally treated. And we have data from trials supporting the efficacy of the other drug classes, but it's even more important to now have data, more and more data from daily clinical practice and representative patients of our daily clinical practice about how they work. And we see here efficacy shown and demonstrated in patients switching from TNF to either UPA or to IL-17 inhibitors, or even in patients staying in TNF inhibitors. So I think that's the first message, and that's reassuring, and we like to see this type of data. And without wanting to be too critical, let's discuss about what I think we know there's the potential effect of JAK inhibitors on modulating pain beyond simply the effect of disease activity. So the question is that what we are seeing here? And therefore, patients that go from TNF inhibitors to upadacitinib have a better response than to pain and then to modulating pain? Or can it also be that there's some confounding by indication, and a rheumatologist chose after TNF inhibitor to give upadacitinib to those that had eventually better likelihood of response compared to giving another TNF inhibitor? Do you have any thoughts on this?
Well, I don't think that we can answer the second question simply because we do not know, obviously. Yes, it might very well be. But on the other hand, we do assume, theoretically at least, that the JAK inhibition, due to the small molecule size, might have a central effect and also modulate pain differently. However, we also found that the peripheral arthritis was beneficially affected here. So the question is overall, why is that? Is the broader inhibition of cytokines maybe superior to targeting a cytokine in the second stage of treatment? Obviously, in that case, I have to say I do not know. It makes sense to me, absolutely. What we do not know is obviously what happened thereafter, after the study observation followed. So we did have, as I mentioned, 3 point something, or about 3 years of treatment. So this is a different follow-up. We need to know what happens with upadacitinib as well later on. So that's a caveat here. But overall, I think that this data is extremely interesting and important. That's why I also supported them, because they do show that switching to another mode of action is something that we should certainly take into account. And indeed, maybe possibly, as I mentioned in the beginning, going more broadly rather than targeting a specific cytokine make sense in those secondary non-responders.
Yeah, and the truth is that in those patients that do not respond, which is the case in which this analysis, in whom this analysis is being done, we don't know yet know why, but there are patients that respond better to one molecule than to the other. So this is not surprising, and it's good to reassuring that, again, as I started, that there are drugs efficacious for those not responding to the first drug. Ideally, we would like at the beginning to know who is the patient going to respond to JAK inhibitor or TNF or IL-17. But the truth is also that biomarker research has not been very successful. It's very difficult before things happen to predict who is going to respond to each drug class. So it remains to a certain extent a bit of trial and error. And in those that do not respond, then indeed we go to other modes of actions or to other drugs, and reassuringly we see efficacy here. I think that's also, if I hear your summaries, the encouraging or the positive message from this study, isn't it?
Absolutely. Yes, I'm fully in agreement with that.
Good. Okay. Thank you very much. Then I think we will move to our second paper, which is entitled Effectiveness of Ixekizumab in 709 Real-World Patients with Axial Spondyloarthritis and Psoriatic Arthritis, and Nationwide Cohort Study. So in 2018, ixekizumab, which is an IL-17A inhibitor, was marketed for PSA in European Union, included Denmark, because that's the study where the country where this study was conducted. And in 2020, it was marketed for axSpA. And studies of the real-world effectiveness of IL-17 inhibitors in axSpA and PSA of patients who have failed a prior IL-17 inhibitor are scarce. We often see studies on IL-17 inhibitors, but in patients who have previously failed a TNF inhibitor. And here Janssen et al. Explored real-world effectiveness of ixekizumab in Danish patients. They used the well-known DanBio registry, and patients with actual SPA and patients with PSA, and they investigated, on one hand, treatment retention after 6, 12, and 24 months, including whether a previous treatment with other IL-17 inhibitor was the case, and the range of clinical factors that could have impacted the risk of withdrawal. So, as mentioned before, 709 patients were included. Most of them were biological DMARD experienced. So in actual SPA, 97% of the patients, so virtually all patients, had been previously exposed to another biological DMARD, and in PSA, 91%. So this is important to remind or remember which type of patients we are talking about, and now interpret the efficacy findings or effectiveness findings in light of the population that we have. So major patients failing a previous biological DMARD treatment. The 6, the 12, and the 24-month retention rates were for actual SPA 69%, 53%, and 40%, that patients were retained on ixekizumab, and for PSA 75, 63, and 51. So a little bit higher in PSA if we compare the numbers with actual SPA. Also in actual SPA, we saw that even more patients had been previously exposed to another biological DMARD. 24-month retention rates were 40% for actual SPA, and again, a little bit higher, 51% for PSA patients on ixekizumab. For actual SPA and PSA, patients that were previously treated with IL-17, so it was secukinumab, if they had been previously treated with it, they had a 24-month retention rate that was lower than in those patients that were IL-17 naive. Patients that were previously treated with another IL-17 inhibitor had thus an increased risk of withdrawal. In actual SPA, 36%, and in PSA, 34%. However, neither the smoking status nor radiographic status were associated with withdrawal in actual SPA, and in PSA, the concomitant methotrexate was not associated with withdrawal. So after 6 months, 24% of patients with axSpA had ASDAS below 2.1, so low disease activity or inactive disease, and 5% were in inactive disease, so ASDAS inactive disease. For PSA, using the DAPSA low disease activity, this was achieved in 43% of the patients and remission in 10% of the patients. So in conclusion, in this nationwide observational study, ixekizumab was mainly used in patients with axSpA and PSA who had previously failed multiple biologic or targeted synthetic DMARDs, certainly including either IL-17 inhibitors, and although prior IL-17 inhibitor treatment was associated with increased risk of withdrawal in both groups, so in axSpA and PSA, there was a relatively high retention rate and improvement in all disease outcomes, suggesting that or showing that ixekizumab is a viable option for challenging patients that have already multiple biological or targeted synthetic DMARD failures. So I think this is the summary of this study, Xenofon, and now I think it's good to open it for discussion, and I'm curious about your thoughts about it.
Yes, thank you. And I think we need to discuss this in a way of giving our own conclusions. And I believe that these data go very much in line or are very much in line with what we know, the experience we have with switching to another class of drug, either the same or another mode of action. So knowing that if a biologic is failing, of course, we do not have any other option. I do agree with that, to go to another biologic or to JAK, as I showed in the first study. However, I believe the maybe most interesting thing about it is something we do not really know otherwise, as compared at least to the large number of data we have from TNF blockers, that switching from IL-17 to an IL-17 inhibitor still makes sense. The molecules are not the same. IL-17 inhibition with one or the other compound, it's just not the same, and it makes sense to really consider it, especially if, for example, in this case with IL-17 inhibition, we are considering also the very good safety profile, but also some other characteristics where we would like to keep the patient on an IL-17 inhibition.
Yeah, thank you. I interpreted exactly, and I was going to emphasize exactly the same as you. We could look at this looking at whether the glass is half empty or half full, but I think it's half full because although patients that have had previously an IL-17 inhibitor have a higher rate or a higher likelihood of withdrawal from treatment, that's not surprising because we know that when patients have more failures, they are more difficult to treat. But still, the positive message is indeed although patients have had previously either TNF inhibitors or another IL-17 inhibitor, and there is not much data on this, is still meaningful to give another IL-17 inhibitor. There are patients responding to ixekizumab that haven't responded to secukinumab, and in daily clinical practice we have certainly also come across the opposite, patients that did not respond to ixekizumab that then responded to secukinumab. So I think the two papers are well aligned. What we discussed in both papers, that indeed patients failing treatment with one drug class or one drug, there is still there are patients that respond to other drugs even within the same drug class or within other drug classes. So I think this is the summary from my side. Any other things you would like to add, Xenofon?
Well, I would like to add indeed that both our studies here show that we do achieve good results based on the switch of our patients to another, most probably to another, but also partly to the same, which is new. The thing that is new here is the IL-17 inhibition switch. So I believe for daily practice, what we can take out of this is that obviously switching is, there's no alternative to it, but I would rather suggest to the colleagues who are listening to not wait too long with a switch once the drug is not working, obviously. So I wouldn't directly think about switching, but if the drug loses effect, then it makes sense to really get the patient's burden down by switching to another biologic, based obviously on the clinical situation of the individual patient. But I think these are two very positive studies for positive information, and they also confirm daily practice.
Yes, totally agree with you. And in line with what you said, I think it's important to emphasize the importance of continuing measuring outcomes in our patients, and particularly disease activity using the ASDAS. And in case of patients not responding, not achieving desirable outcomes, at least and ASDAs below 2.1, I think it's good to consider when we are facing presence of inflammatory activity to consider switching, indeed, as you were saying.
Yes, so I think we are coming to an end and to a nice conclusion. Thank you for joining us in this Access Spondyloarthritis podcast brought to you by the Immune-Mediated Inflammatory Disease Forum. We do hope you enjoyed and found it useful. If you did, please don't forget to subscribe to our channels on YouTube, SoundCloud, Spotify, or wherever you get your podcasts from so that you don't miss any future episodes. If you want to read more about what we've discussed today, head over to www.imitforum.com where you'll find summary slides of today's publication. See you next time.